Can dual, energy computed tomography be used to identify early calcium crystal deposition in the knees of patients with calcium pyrophosphate deposition? Abstract. Objective, to assess the ability of dual, energy computed tomography, DECT, in identifying early calcium crystal deposition in menisci and articular cartilage of the knee, depending on the presence-absence of chondrocalcinosis seen on conventional CT. Methods: 130, 2 knee DECT scans from patients with suspected crystal associated arthropathy were reviewed and assigned to a calcium pyrophosphate deposition, CPPD, group, N equals 50, or a control group, N equals 82. 5 DECT attenuation parameters were measured in preset regions of interest, ROIS, in menisci and articular cartilage and compared between groups using linear mixed models with adjustment for confounders. Subgroup analysis, excluding ROIS with chondrocalcinosis seen on conventional CT, was performed. Results, in both menisci and articular cartilage, and for all 5 DECT attenuation parameters, calcified ROIS in CPPD patients showed significantly higher values than ROIS in controls, p. 0.036. Conversely, non-calcified ROIS in CPPD patients were comparable with those in controls, p. 0.09. While specific DECT parameters yielded good accuracy, area under the curve AUC 0. 87 0.88, in differentiating calcified ROIS in CPPD patients from ROIS in controls, DECT failed to distinguish between non-calcified ROIS in CPPD patients and controls, AUC 0.58 to 0.59. Conclusion: while DECT has the potential to characterize knee intra-articular mineralization, this technique cannot yet accurately identify early calcium crystal deposition that is not visible as chondrocalcinosis on conventional CT. Hospitalized infections in lupus, a nationwide study of types of infections, time trends, healthcare utilization, and in hospital mortality. Abstract. Objective, to examine the time trends in hospitalized infections in patients with systemic lupus erythematosus, SLE, and the factors associated with healthcare utilization and in hospital mortality. Methods: U.S. national inpatient sample data from 1998-2016 were used to examine the epidemiology, time trends, and outcomes of 5 common hospitalized infections in patients with SLE, namely, pneumonia, sepsis, bacteremia, urinary tract infection, UTI, skin and soft tissue infections, SSDIs, and opportunistic infections, OIS. Time trends were compared using the Cochrane, Armitage test. Multivariable, adjusted logistic regression models were used to examine the factors associated with healthcare utilization, hospital stay greater than 3 days, hospital charges above the median, or discharge to a non-home setting, and in hospital mortality. Results: hospitalization rates per 100,000 claims among SLE patients in 1998-2000 versus in 2015-2016 were as follows: for OIS, 1.13 versus 1.61, 1.2 fold increase; for SSDIs, 4.78 versus 12.2, 2.5 fold increase; for UTI, 1.94 versus 6.12, 3.2 fold increase; for pneumonia, 15.09 versus 17.05, 1.1 fold increase; and for sepsis, 6.31 versus 39.64, 6.3 fold increase. In 2011-2012, sepsis surpassed pneumonia as the most common hospitalized infection in patients with SLE. In multivariable, adjusted models, a diagnosis of sepsis, older age, a DAO, Charlson Common Comorbidities score of 2, having Medicare or Medicaid insurance, and urban hospital location were significantly associated with increased odds of in-hospital mortality and with all healthcare utilization outcomes. African American race was significantly associated with increased odds of healthcare utilization. Conclusion: the results of this study indicate that the rates of hospitalized infections increased over time in patients with SLE, and that pneumonia was surpassed by sepsis as the most common hospitalized infection. In addition, associations of risk factors with poorer outcomes were identified. These findings may help inform patients, providers, and policymakers with regard to the burden of infection in SLE, and could lead to interventions pathways to improve outcomes. Prevalence and associated factors of electrocardiogram abnormalities in patients with systemic lupus erythematosus, a machine learning study. Abstract. Objectives: electrocardiogram, ECG, abnormalities are predictive of subsequent cardiovascular events. Cardiac involvement is common in systemic lupus erythematosus, SLE. We aim to determine the prevalence of ECG abnormalities in SLE patients and to examine the factors associated with ECG abnormalities with machine learning approaches. Methods: consecutive SLE patients' records were retrieved from the database of the hospital for the cross-sectional study. Abnormal ECGs with clinical significance were grouped into tachyarrhythmias, atrioventricular block, nonspecific ST segment changes, T-wave abnormalities, ventricular hypertrophy, axis deviation, bundle branch block, and QT interval prolongation. Associated factors of the most common ECG abnormalities were assessed by comparing logistic regression and 4 other machine learning approaches. Results: 299 patients were enrolled. 128 out of them were clinically significant abnormalities. T-wave changes, 52.3%, nonspecific STT changes, 26.6%, and prolonged QT interval, 8.6%, were the most prevalent abnormalities among patients with abnormal ECG. Random forest models had the best performance in the discovery of associated factors. Age, disease duration, anatiter, disease activity, SLEDAI-2K, were associated with nonspecific STT changes, prolonged QT interval, and T-wave changes. Hypertension, positive anti-SSA, and secondary SJ, Grant syndrome were influential factors for nonspecific STT changes, prolonged QT interval, and T-wave changes specifically. Conclusion: STT changes/T-wave changes were the most common abnormalities seen in ECGs of SLE patients. Our finding suggests that age, longer disease duration, higher disease activity, hypertension, anti-SSA antibody positive, and secondary SJ, Grant syndrome are important, influential factors for these ECG abnormalities. Clinical significance of monitoring hydroxychloroquine levels in patients with systemic lupus erythematosus, a systematic review and meta-analysis. Abstract. Objective: despite the pivotal role that hydroxychloroquine, HCQ, plays in treating systemic lupus erythematosus, SLE, less than 50% of patients take HCQ as prescribed. Measurement of HCQ blood levels can help clinicians distinguish non-adherence versus lack of efficacy of HCQ. Our objective was to systematically review publications and perform a meta-analysis to examine the correlation between HCQ levels and 1. Non-adherence and 2. Systemic lupus erythematosus disease activity index, SLEDAI, scores, in SLE. Methods: a comprehensive search was performed. We included observational and interventional studies that measured HCQ levels and assessed adherence or SLEDAI scores in adults with SLE. Forest plots compared pooled estimates of correlations between HCQ levels and reported non-adherence or SLEDAI scores. Results: among 604 studies screened, 17 were reviewed. We found 3 times higher odds of reported non-adherence in patients with low HCQ levels, odds ratio 2.95, 95% confidence interval, 95% CI, 1. 63, 5.35, p 0.001. The mean SLEDAI score was 3.14 points higher in groups with below threshold HCQ levels on a priori analysis. Equals 3.14, 95% CI 0.05, 6.23, p equals 0.053, and 1.4 points higher in groups with HCQ levels of. Conclusion: we found a strong association between low HCQ levels and reported non-adherence. Our results suggest that HCQ levels of 750 ng/ml might be a potential therapeutic target. Relevant domains and outcome measurement instruments in neuropsychiatric systemic lupus erythematosus, a systematic literature review. Objectives: although neuropsychiatric involvement in systemic lupus erythematosus, NSL, is one of the most complex and troubling manifestations of the disease. Validated outcome instruments to be used as sensitive endpoints in controlled clinical trials are lacking. We set out a systematic literature review, SLR, to identify outcome measurement instruments and domains used to assess NSL. Methods: the preferred reporting items for systematic reviews and meta-analysis, Prisma, guidelines were used. Articles available in English, 1967 to 2020, listed in PubMed, Embase, PsycInfo, Cochrane Library and Euler Outcome Measures Library were screened. All domains and outcome measurement instruments were characterized according to the OMRAC filter 2.1, considering core areas: manifestations, abnormalities, life impact, death lifespan, societal resource use, and contextual factors. Results: of 3,392 abstracts evaluated, 83 studies were included in the SLR, 15,974 patients, females 89.9%. Eligible studies included domains and instruments pertinent to all core areas defined by OMRAC, except for societal resource use. The most common core areas were manifestations, abnormalities, covering 10 domains pertinent to laboratory and instrumental markers, indexes, and neuropsychiatric dimension. Cognitive, neurologic, and psychiatric field, and life impact, covering 7 domains related to physical function. From both the perspective of the patient and the physician, pain, and quality of life. Conclusion: our study revealed great heterogeneity in the instruments derived from populations with ENTL, and none of these had high-quality evidence. This supports the need to develop and further validate a core domain set and outcome measurement instruments to promote clinical research in this field, enhancing comparability across studies. Effectiveness and tolerability of oral versus subcutaneous methotrexate in patients with rheumatoid arthritis. Objectives: the aim of this study was to compare the effectiveness and tolerability between oral methotrexate, MTX, and subcutaneous MTX in a large group of rheumatoid arthritis, RA, patients in a real-life setting. Methods: in this retrospective cohort study, adult patients with clinical diagnosis of RA who started MTX treatment, monotherapy or combined with hydroxychloroquine, either started with oral or subcutaneous MTX. The primary outcome was superiority testing of between group difference in change in DOS-28-CRP between baseline and 3 to 6 months, and subsequent non-inferiority testing, NI margin 0. 6. Analyses in case of non-superiority. Secondary outcomes included MTX dose, side effects, laboratory abnormalities, and use of comedication. Results: 640 RA patients were included, 259 started with oral MTX and 381 with subcutaneous. There was no significant difference in DOS-28-CRP, after adjusting for confounding, 0.13, 95% CI, minus 0.14, 0.40, and oral MTX strategy was non-inferior to subcutaneous. The mean MTX dose was slightly lower for the oral strategy. 18.0 SD 6.9 vs 19.9 SD 8.2, p equals 0.002, which was accompanied by a lower cumulative incidence of adverse events, 41% vs 52%, p equals 0.005. No differences were seen in use of other comedication. Conclusions: starting with oral MTX in RA in a real-life setting is non-inferior to a subcutaneous MTX treatment with regard to disease activity control. At least when used in dosages up to 25 mg and on a background of HCQ co-treatment and a treat-to-target approach. In addition, tolerability was better. This supports the strategy of starting with oral MTX. Impact of rheumatoid arthritis and biologic and targeted synthetic disease-modifying antirheumatic agents on cancer risk and recurrence. Purpose of review: several new therapeutic drugs are now available for the management of rheumatoid arthritis, RA. Given that RA has been associated with an increased risk of certain cancers like lymphoma and lung cancer, concern remains about the safety of newer immunosuppressants used in RA management as it relates to the risk of cancer. Recent findings: most meta-analyses of randomized clinical trials of tumor necrosis factor inhibitors TNFi have not observed an association between TNFi and risk of incident cancer. Studies of non-TNFi biologic disease-modifying antirheumatic drugs, BDMARDs, and targeted synthetic DMARDs and cancer are also reassuring but limited and of short-term follow-up. Regarding the use of DMARDs in patients with RA and a prior malignancy, retrospective studies have shown that TNFi use is not associated with recurrence. Summary: there is a need for ongoing studies on the safety of non-TNF-β-MARDs and targeted synthetic disease-modifying anti-rheumatic drugs and recurrent cancer. Further research is also needed to guide the patients, rheumatologists, and oncologists regarding the safest DMARDs to choose for patients with RA and a recent diagnosis of cancer. Evaluation of cardiopulmonary exercise test in the prediction of disease progression in systemic sclerosis. Objectives: cardiopulmonary exercise test, CPET, is a widely used examination to predict the prognosis of many chronic pulmonary diseases. And it has also been tested in systemic sclerosis, SSC, with a focus on the development of pulmonary hypertension. CPET is a highly informative non-invasive tool that provides a more complex information than conventional lung function tests to predict the course of cardiopulmonary diseases, as it provides a general overview of the aerobic metabolism influenced by pulmonary, cardiovascular, and peripheral muscle function. The purpose of this investigation was to assess if the progression and the development of poor overall disease outcome in SSC can be predicted by this method. Methods: 29 SSC patients were investigated prospectively with standard follow-up plus CPET for a mean of 3.7 years to match the results of conventional evaluation modalities and CPET. A composite endpoint of several serious outcomes reflecting SSC-related vascular and cardiopulmonary damage was set up, and the predictive value of and correlations between the CPET parameters and resting lung function and echocardiography variables were assessed. Results: none of the clinical parameters, resting lung function or echocardiographic test results proved to be predictive of the development of the endpoint of poor prognosis in this cohort. In contrast, several CPET parameters were found to discriminate between SSC patients with or without adverse outcome. The detection of desaturation, at any CPET test, was associated with a higher risk of poor prognosis, or 5. VO2 and VE/VCO2 at baseline correlated with the annual decrease in FVC, anaerobic threshold with the development of digital ulcers, and VE/VO2 with the increase in pulmonary arterial pressure. Conclusions: several CPET parameters obtained at the beginning of follow-up are informative of the appearance of various adverse endpoints. CPET is a feasible examination in the care of SSC patients and provides excess information to current standard follow-up examinations. Increased risk of severe infections and mortality in patients with newly diagnosed systemic lupus erythematosus, a population-based study. Objective: to evaluate the risk of severe infection and infection-related mortality among patients with newly diagnosed systemic lupus erythematosus, SLE. Methods: we conducted an age and gender-matched cohort study of all patients with incident SLE between January 1, 1997 and March 31, 2015 using administrative health data from British Columbia, Canada. Primary outcome was the first severe infection after SLE onset necessitating hospitalization or occurring during hospitalization. Secondary outcomes were total number of severe infections and infection-related mortality. Results: we identified 5,169 SLE patients and matched them with 25,845 non-SLE individuals from the general population, yielding 955 and 1,986 first severe infections during 48,367 and 260,712 person-years follow-up, respectively. The crude incidence rate ratios for first severe infection and infection-related mortality were 2.59, 95% CI, 2.39 to 2.80, and 2.20, 95% CI, 1.76 to 2.73, respectively. The corresponding adjusted hazard ratios were 1.82, 95% CI, 1.66 to 1.99, and 1.61, 95% CI, 1.24 to 2.08. SLE patients had an increased risk of a greater total number of severe infections with crude rate ratio of 3.24, 95% CI, 3.06 to 3.43, and adjusted rate ratio of 2.07, 95% CI, 1.82 to 2.36. Conclusion: SLE is associated with increased risks of first severe infection, 1.8-fold, a greater total number of severe infections, 2.1-fold, and infection-related mortality, 1.6-fold. Comparison of fracture risk between proton pump inhibitors and histamine 2 receptor antagonists in ANCA-associated vasculitis patients, a nested case control study. Abstract. Objective, whether acid suppressants, proton pump inhibitors, PPIs, and histamine 2 receptor antagonists, H2RAS, are associated with bone fractures in patients with ANCA-associated vasculitis, AAV, treated with glucocorticoids remains unclear. This study compared PPIs with H2RAS in terms of the risk of bone fractures in patients with AAV who received in-hospital induction therapy with glucocorticoids. Methods: we retrospectively identified 149 patients with fractures among 22,821 patients newly diagnosed with AAV in 1,730 hospitals using a nationwide inpatient database from July 2010 to March 2018. We conducted 1:4 case control matching. Age, sex, duration of AAV treatment and fiscal year were matched between the cases and controls. A conditional logistic regression analysis was conducted to assess the association between acid suppressants and fractures. Results: of all enrolled patients with fractures, the median age was 77 years, and 99.66% were female. The median duration from AAV treatment to fracture was 52 days. The proportion of patients using PPIs was 91.3%, 136 of 149, and 80.2%, 478 of 596, in the case and control groups, respectively. Compared with H2RA use, PPI use was significantly associated with fractures after adjustment for age, sex, BMI, smoking habit, Charlson Comorbidity Index, renal failure, bisphosphonate and same fiscal year according to a multivariate analysis, adjusted odds ratio, 3.76, 95% CI, 1.37, 10.3. Conclusion: PPI users had a higher risk of fractures than H2RA users among mostly advanced stage patients with AAV with remission induction therapy.